Our first session today is Transitions of Care. This is being presented by Karen Kinahan and Jennifer Reichek. Karen Kinahan, hold on one second, excuse me. Karen Kinahan is a nurse practitioner at Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Karen has spent her entire 34-year nursing career in oncology and has spent the last 26 years working in cancer survivorship exclusively, primarily with adult survivors of childhood cancers through the STAR program, a program she started in 2001 at Northwestern. She helps facilitate long-term follow-up care for hundreds of childhood cancer survivors and their families as they transition out of the pediatric setting and assists older survivors in finding comprehensive long-term follow-up survivorship care. Karen has been active in research primarily around the transition period from pediatric to adult. Her doctoral work promoted the shared care model for AYAs, connecting them to primary care. Karen has been invited to present at numerous national and international conferences to present her work and share her expertise. Dr. Reichek is a pediatric oncologist at Ann and Robert H. Lurie Children's Hospital of Chicago and the director of the STAR, Survivors Taking Action and Responsibility program, as well as the director of Lurie Children's AYA program. Dr. Reichek received her MSW from Smith College School for Social Work and worked as a psychotherapist with adolescents in an inpatient and residential treatment facility prior to entering medicine. She attended medical school at MCP, Hahnemann, and did her residency and fellowship in hematology oncology at Children's Hospital of Philadelphia. She spent her medical career focused on adolescents and young adults with solid tumors and survivorship issues, including the transition from pediatric to adult medical care. Dr. Reichek's research has focused on the AYA population with special attention to psychosocial needs and long-term sequelae of pediatric cancer treatment. She is active in the COG AYA committee and has presented her work at national and international conferences. So I would like to pass the screen over to Karen Kinahan.
Okay, thanks, Betty. Everybody see my slides? Yes?
We can.
Okay, great. So thanks so much for inviting me to be here today to talk about transitions of care. And this has been a really, I think, a fabulous symposium over the last 4 sessions. And hopefully today we're going to focus on the topic of transitions and hear from some patients and talk to Dr. Brad Zebrak later on. And Jennifer Reichek will be following me. So the first slide I'm going to show, which is my slides advance, okay, is this one. So why AYA? So why adolescent young adults? And essentially, this is something I actually learned about AYA patients back about 20 years ago, exactly at the first COG meeting. And Dr. Archie Blyer put this new committee on the docket for COG and thought, all right, I'll go to this and see what it's all about. And it's really actually been remarkable to see kind of all the work that's been done over the last 20 years. A lot of what we've touched on here in this conference, clinical trial enrollment, survival rates, unique issues that patients have. And one of the things I had to change on this slide, because this originally said 70,000 patients being diagnosed per year, which is a number we've been kind of going off of, was that in 2020, the American Cancer Society reported that 89,500 patients of new cancer cases in AYAs between 15 to 39 are diagnosed in the United States. So this number has jumped up, and it's led us now to even be more dedicated, I guess, to this population and think about these unique issues that they have and try to take best care of them that we can. So I was asked to specifically talk about transitions of care, and specific to that, from on treatment to off treatment. So when Betty and I were first talking months ago about the presentation and what they, kind of were looking to hear about, she had given me a summary of some discussions that the consortium had about transitions of care, and I summarized their summary, I guess, for you today. And I want to read this because I feel like it's important to kind of talk about a lot of the topics and issues that patients in this arena have. So abandonment feeling, not knowing what's next, mental health issues arise, need more education on this, SSRIs, counseling, back to a social life, reconnecting with friends, dealing with lost friendships, scan anxiety, the fear of recurrence, and we need resources for this, back to school, work, leaving for college, changing career, wanting a space for survivorship online, a community or a portal. Their patients are a legal adult at 18 and a lot of times off their family insurance at 26, transitioning from the pediatric to adult care, not having a PCP, getting one, survivorship clinics, moving to another city, finding care, and the responsibilities that AYAs have, paying bills, making appointments, and staying organized. So I'm going to touch on a lot of these. I don't have all the answers for all of them, of course, but it's a good topic, I think. I'm glad I'm able to talk about this. So I would start just by kind of going back a little bit to basically tell you about the National Coalition for Cancer Survivorship, and I'll tell you why in a second. So this was a patient-centered advocacy organization, started in 1986, and one of their first goals was to replace the word cancer victim with cancer survivor, and I feel like they've successfully done that. They educate government agencies and policymakers about the need for good quality care throughout the cancer survivorship continuum. And they've also changed, I think, the definition that most of us abide by, but that cancer survivor is from the time of diagnosis to the balance of life, and also that includes family, friends, and caregivers. So this slide shows Dr. Fitzmullen, who was actually one of the co-founders of the NCCS in 1985 when this first began. He was, like I said, a cancer patient, and he described the state of cancer care, and I'll read his quote, as if we've invented sophisticated techniques to save people from drowning, but once they've been pulled from the water, we leave them on the dock to cough and sputter on their own and believe that we've done all we can. I thought this was a little bit fitting, and I feel like hopefully we've done a better job than that, but I do feel like we definitely have work to do with kind of giving resources to patients. He described the seasons of survivorship as acute survival, the time after diagnosis, extended survival when treatment is completed, that's what I'm going to mainly focus on, and then permanent survival where recurrence seems unlikely, but yet long-term effects will continue. And a lot of discussions and talks I give are on survivorship, so I am going to talk a little bit about that because I think it's an important piece of this transition off treatment talk. A slide by Linda Jacobs and Schulman where they talked about potential long and late-term effects. And we all know that not everybody has all of these effects. So there are patients that we're going to see with sexual dysfunction and hot flashes and peripheral neuropathy, sleep problems, fatigue. And in the center of that then becomes the effects that they have on the patients, such as psychosocial issues, loss maybe of employment, not being able to go back to work, losing their job, spiritual issues. And at the center of that here is a cancer survivor. And I think most of us will agree too that does include, maybe in our case for AYA, the parents, the siblings, the spouse, caregivers for these patients. So I thought this was a nice demonstration of some of the potential late effects. With this slide, sort of similar, maybe focusing a little bit more on just childhood and adolescent cancer, and this is from Les Robeson and Melissa Hudson. We're looking at some of the psychosocial issues, the same: mental health, education, employment, health insurance. Certainly worried about recurrent primary cancers and subsequent neoplasms, so secondary cancers, fertility, reproduction, which we heard from Dana and Kristen about that. And we're not hearing too much in these talks about organ function and more late, medical late effects of cardiac, endocrine. Touch a little bit on that, but obviously it's a broad topic of survivorship. And again, maybe this is focused a little bit more towards adolescent and child, but I think we can gather that there's important topics here. So one of the studies, or one of the, not even a study, resource that we've learned so much in pediatric and young adult cancer is from the Child Cancer Survivor Study. And many of you are familiar with this and maybe even have been involved with this, but I felt it's worth sharing. This is a study that was funded in 1994, where we have a retrospective cohort of patients who, with an expansion, were diagnosed between 1970 and 99. There are now 31 contributing centers, perhaps even more now. 5-year survival of different cancers: leukemia, lymphoma, brain cancer, bone cancer, neuroblastoma, and soft tissue sarcoma. And they have very detailed treatment information and a wide range of outcomes in many, many, many studies. But one of the first studies that really sort of, I think, hit the ground and really got attention was a study by Kevin Effinger and colleagues from the CCSS, where they looked at chronic health conditions in adult survivors of childhood cancer. And this goes back to 2006, was published in the New England Journal of Medicine. And there were 10,397 survivors who were diagnosed in that earlier time period from the CCSS, but at that time were 18 years average post-diagnosis, and then they have sibling controls as their control group. They use the common terminology criteria for adverse events, the CTCAE as it's called, from the NCI, with a graded health conditions. And a grade 1 condition simply is something more mild, maybe mild hearing loss or hypertension that doesn't require medication. Grade 2 is a little bit more moderate, a cataract that requires surgery, abnormal pulmonary function test, for example. Grade 3 is more severe, something that's interfering with their ADLs, when we have surgery that's needed. Grade 4 is life-threatening or disabling, such as stroke or cardiac arrest, and then grade 5 being death. So there's a lot of slides to go with this, but in lieu of time, I just kind of had to cut to the summary slides here, and that was that you've probably seen this in the literature, but by 30 years post-cancer, 73% will have one condition, 42% will have the higher grade conditions, and 32% of patients would have multiple conditions. And again, this is 30 years post-cancer. And I think this slide is the same data, but it shows us here that this trajectory is not, it's not plateauing and it's not going down with years of diagnosis, but it's continuing to rise, even these higher grade conditions. So that's why I think this kind of got a lot of attention back in 2006. And I feel like for childhood cancer and adult survivors of childhood cancer, at least, who are, again, young adults, that this sort of put out the page, like we really do need to have continued follow-up care for these patients. Another follow-up study, similar data here from Greg Armstrong, looked at these high-grade conditions by organ system. And here, this is age of patients, so older ages, 40 to 50. Survivor versus sibling here, a significant difference with new malignancies and cardiac late effects. Others as well, but these were the two significant ones. And so we have been providing screening and surveillance, in particular with these type of issues, but that's if patients are getting screening and surveillance. So I think that's also important to mention. So again, a little bit of the history, kind of the Institute of Medicine's, their call to action, that started back around 2003, where they recommended to develop clinical-based guidelines for childhood cancer survivors. And that came out, as I said, the COG guidelines in 2003. I was personally really happy about this because I had been doing survivorship prior to that. And I always wish, boy, I wish we had guidelines for follow-up care. Finally, we did. A little bit later, I got more of us to focus on the adults. A symposium that took place, and this is the summary of that, was called From Cancer Patient to Cancer Survivor, Loss in Transition. And the recommendation for this, as many of you may know and are maybe still working on now, is that every cancer survivor should receive a survivorship care plan, which contains their treatment summary, late effects, signs of recurrence, their team members, identification providers, and lifestyle recommendations. So that, as you can hear, that was recommended many years ago. And the reason being, and simply said by this loss in transition, is that many people finish their primary treatment for cancer unaware of their heightened risks and are ill prepared to manage their future healthcare needs. So I think that's true. And I think this is kind of like this transition where we really kind of need to focus and do what we can do for them. Some of the key components the IOM recommends for high quality survivorship care include these prevention, so that's prevention of recurrent and new cancers and late effects. Surveillance, and that can be anything from scans off therapy to looking for recurrence or secondary cancers. So breast imaging, for example, for a woman that's had chest radiation, colonoscopies early. So some of the recommendations that are in the guidelines, and also not forgetting about the psychosocial and psychosocial effects that can occur off therapy and even years later, providing interventions for this. And then care coordination is another component. And this is, I think, particularly important for our AYA age range, and Jens will talk about this a little bit later, where patients might be diagnosed at one hospital, get treatment there, and then maybe transition either to another adult center or maybe even not a survivorship program per se, but just a primary care provider. So kind of helping them coordinate that. And then also we can't forget about health insurance, which is always important for them to know to have it, keep it, do what we can do in employment. And that might be filling out forms for them, advocating like with FMLA paperwork, et cetera. So lots to do in the survivorship world. So getting back to transition and AYA cancer transitions, and what's a transition? So it's described as a complex a process suggestive of a passage or movement from one space or time to another, and it does involve some degree of self-redefinition. And changes in health, as you can imagine, will cause a transition from being a healthy 22-year-old to now being a patient undergoing cancer treatment to then survivorship and maybe getting back into life. So lots of transitions along the way. And I was reading a position statement paper from the Canadian Task Force on AYA and some other articles and stuff too, preparing for today and looking at some of the inequities of care of the AYA. And basically a lot of themes were very common. And it says as patients navigate through transition process, they may experience disequilibrium, a sense of imbalance, feeling of uncertainty, confusion, anxiety, and despair. And I think as you'll hear me talk, you'll hear some common repeating of these words, because that's kind of what I discovered doing my literature review for this talk. This slide sort of shows some of the critical transitions, kind of just moving on. Obviously, we talked about the diagnosis and the therapy here. It's a good time to review the treatment exposures and their risks. And it's also education about like what guidelines are recommended and healthcare behavior, lifestyle behaviors, et cetera, especially in this AYA group. And just depending on where the patient's treated, they may kind of go into a quote long-term follow-up program or have a survivorship visit, maybe still following up with their medical oncology team. That's sort of how we do it. But at some point during the end of therapy or within survivorship that they should receive this care plan. I am a strong believer in that. Have it reviewed, have it in their hands, going over it so they understand kind of what their issues are. And then Jen's going to talk more about this transition to the adult setting. So this study I found, I'm going to call it a small and mighty study from Thompson and out of Australia, where they looked at transition from active therapy to follow-up care, the topic I'm talking on, and used a small N with grounded theory techniques, looking again from what were the issues, three main issues of concern with active therapy to follow-up care. Number one was information provision and communication. And that is simply described as the delivery of information by the healthcare providers. It was in a manner not understood or targeted at the developmental stage of a young person. So I think that's something we've heard about communication on the first day, but also we have a wide range of patients here that we're talking to. Even in the adult setting where I work now, we might have a 22-year-old and then in the AYA, like a 38-year-old. So how are you going to talk with them? I think we need to look at the delivery of our information and how it's being understood. The second was treatment process highlighted, and that was lack of skilled and timely interventions, and fertility options were brought up on that topic. And then post-treatment and survivorship. And this kind of surprised me, but it said the months following treatment loomed as the main medical and psychological concern related to diagnosis. Fear of recurrence, uncertainty of future care, and the continued need for structured support during the active therapy period. So again, some of the same themes, but I thought that just was surprising that they said the main medical and psychological concern was after therapy. I liked these quotes from this paper, and it was regarding kind of finishing treatment. So I'm going to read them because I feel like it's fitting for this. It says, this woman, 28 years old, I felt like I'd gone from having all these supportive people around me, nurses, doctors, my social worker, to being completely on my own. A young man, 24 years old, said, I left the hospital after my last chemotherapy. The doctor said, see you in 3 months. I was like, 3 months? What am I going to do for 3 months? And I kind of chuckled at that when I read it. But at the same time, I could see patients feeling this way, like, wait, I don't like being here, but I don't want to not be here. Like that they kind of need to still feel engaged and part of, what's going on and have this access. And then this one also, my first meeting with my radiation oncologist raised that there could be a chance of second cancer due to my treatment. It was never discussed again. I've been thinking a lot about it recently. And that's concerning. And I think this is probably what happens all the time, but this is a time and opportunity to mitigate that and to have these discussions about, yes, you have this risk, but we're going to worry about it in this way and by doing these tests, et cetera, down the road, and just giving the power of information really to not have them have this on their mind, maybe needlessly. Uh-oh. Okay. Oh no. Oh my gosh, are you kidding me? Hold on. What just happened?
We can see a change in slide on our end, Karen.
Okay. Oh gosh. Wow, that was weird. All right. Sorry about that. So as you can, just from what I'm talking about, difficult transitions for these AYAs. We have patients trying to become themselves and become a young adult or older adult, getting a job, and now they're a cancer patient to cancer survivor. Seems that they have a perceived reduction in support, whether that's true or not, and these obviously longer intervals between appointments, and a time to reflect on some of what happened to them. And I do see this in clinic. I see patients probably within a lot of times the first 6 or so months after completion of therapy. And that's almost a time when you have time to sit with them and like they can be like, wow, yeah, that was rough. And now I'm trying to move forward, and a time to maybe think about, yeah, I'm struggling still, and time to talk about it. So, and then I think also I wanted to mention with the time that this age range, maybe in any cancer patient, I suppose, it's not a time when being sick and being unwell and having to do appointments is expected or even welcome. So I think that's something to remember with this AYA age range, and then reentry to quote, what is the new normal? So from the literature and just, experience, that this new normal life is looking more like where the focus is on long-term follow-up care with periodic evaluations. We have, again, feeling exposed and vulnerable. They need to return to roles of activities of daily living and physical functioning. And again, this is a big struggle for them. So regaining sense of normalcy, reestablishing peer and family relationships. And I think peer especially with the younger patients perhaps, and I don't know this for a fact, but it seems kind of makes sense that a lot of young teens, they might not be there for them or might perceive that they're not there for them or don't even know what to say, right? And so now they kind of need to re-engage when treatments are over. And then this anxiety, the fear of relapse and recurrence, and that's a real thing for sure. One thing I've said, and whether it's useful or not, I don't know, but when this comes up, and it does from time to time, especially with like lymphoma patients, that, kind of reframing it, like you're feeling well, you're looking well, you're doing well. Think of this as a reassurance that everything's okay versus a reassurance that something's wrong, So that's, I don't know what that's worth, but that's kind of how I've talked with patients about anxiety and how to like cope a little bit better with that. And then we'll hear more about post-traumatic stress and post-traumatic growth. But post-traumatic growth, I think, is interesting too. And just from experience, I've seen that some patients, especially just getting done with treatment, they may not be ready to give back and like to pay it forward yet, But when this does come up and you can maybe share like opportunities for them, it's great and they're ready to do it, but it's not something we can push on them early until they're ready. So that's just one thing I'll say about post-traumatic growth, and that's in the literature also. Kind of maybe a newer phenomenon than post-traumatic stress. So the other study I wanted to share was one that had a bigger end, main challenges of AYA and transition to survivorship, because this surprised me a little bit. They talked about, again, the barriers or challenges, and out of 934, there were 462 physical categories, physical issues. So reduced physical capacity, fatigue, side effects, pain, scars, cognitive changes. So that was 49.5% of all the responses. And I guess it just surprised me. I thought it's worth sharing that maybe we need to focus a little bit more also, not less on the psychosocial, but also pay attention to physical. How are they, how's the physical functioning, and are they getting back? Are they able to take walks? Things like that. Then I kind of already talked about the psychosocial, and that was 25.1%. So kind of getting back a little bit here to survivorship care. I think simply said, one size does not fit all. I come from a place that has a pretty strong survivorship program and has had it for a number of years. But the age of the patient, that might be a factor, comorbidities, the disease type, there's maybe not a survivorship program for all disease types. And that's the case with us too. Stage, metastatic, there's not a program, quote unquote, or we don't see those patients. And then of course the treatment given, and I think that's key in educating patients about what treatment they had and kind of what is the survivorship care looks like, and trying to find what's available to them. This is a patient, Lauren, and it's kind of a funny story, who is on our patient advisory board, and she came from Lurie Children's or Children's Memorial back in 2003, and her statement to me was, well, they kicked me out, and she just was so angry in a sense. And her and I've had a long 18-year relationship now, but she spoke at a few events for me. She joined our advisory board. She's on board 39, the young adult advisory board, here at the walk. And it takes time. It takes time to kind of absorb this sometimes. And I really appreciate her personality and her I don't know, just a lot of good stories about her. But she's great, and I just wanted to share that it's not something that people are going to jump right into and accept all these transitions that we make them do. Again, here, this is a girl, like, let's do this, like, who's my quarterback, let's talk about my bone health and my sexual health. But maybe in the back of their mind, still fears of recurrence and planning for their future. So while we want everybody to kind of be pumped up, ready to go, we have to be patient and take it as it comes. But we do need a coordinated team approach, and I think that's important, that we need to talk about transitions and upcoming transitions, and whether that's survivorship care or clinics, whatever, we need to discuss that early. There's a coordinated approach, especially when we talk about this AYA group, a population that it might be pediatric, they might move to an adult cancer center, they might have a PCP or a pediatrician. So it includes a lot of systems and multidisciplinary and multi-system. And the key is that we do need to empower patients and their parents and their partners and kids and whoever is with them about the treatment history, the current potential health issues, and very importantly about the need for lifelong monitoring, because as that slide from Dr. Kevin Effinger showed, that these late effects do happen, and that even if they're asymptomatic, and it's easy to be a year off therapy and be like, I feel great, and like sweep it under the rug, I don't need to worry about this. But I think our part of our job is to educate them on lifelong monitoring and kind of getting knowledge about what is needed to be done. And this is going to help our young adults especially promote with self-efficacy and their autonomy when they move to an adult setting. We also have to consider health literacy. So we're going to hear from Brad Zebrak later, but a study that he did reported on unmet needs for the age-appropriate internet sites for AYA, for example. So especially the younger ages. So maybe kind of looking at what we have available to them. And then there's a difference in health literacy and like what kind of information do they want and how they want to get it. So a lot of challenges that we have still, and there's more available, but like we still need to figure out like what's working best. So looking at our methods of how we're giving and providing this information, because again, the optimal self-care and management is kind of what we're leaning towards and what we're hoping for. So within that self-care and care comes, I think I have to talk about this, the gap with primary care. And I think the issue is that we really do need their help. So kind of breaking it down to non-modifiable risk factors, and that is the patient's age, gender, ethnicity, family history, and their cancer type and the treatment that they had. But what's modifiable is, and even if you take cancer out of the equation, there are issues that, people in general, but cancer survivors are sometimes left with after is hypertension, hyperlipidemia, heart disease, obesity, diabetes, smoking, and just as patients age too. So these are what primary care providers are trained in. And I really do believe in this model of the shared care model, where making sure patients have a primary care provider and involving them in the care, not at the end of treatment or 5 years later, but earlier on. So I'm just going to kind of go through this if I can with my cursor. So pre-cancer, they have a primary care provider. And I think I will say in the young adult, this is probably not always the case. They might have had a pediatrician, they don't have a primary care provider, they didn't need one, etc. But now they're diagnosed with cancer. And then the oncologist is going to be their main player for sure, because they're there, the team, they have lots of visits. Our job here is these points of communication, to communicate back to the primary care provider, which is a lot of times with a click of a button to send a note. And if they don't have a primary care provider, to get one early, like not necessarily waiting till here, because that way they'll have more involvement and understanding of what the patient went through. But again, these points of communication need to continue. So this is the shared care model from Effinger and McCabe, and a model I really do believe in, especially for this, young adults who are a lot of times in the transition between pediatricians, adult care, and then obviously the other oncology care that goes along with it. So how else can we advocate for the AYAs in our setting? So just looking about where you live and refer to settings that have experience with young adult cancer, that may offer clinical trials and research and programs, identifying your champion in your city. And I was thinking like, maybe that's you, because you're here on a Friday in June listening to this conversation. And so learning the information that we have and educating your team about the unique needs of the AYA, and consider starting a multidisciplinary working group or support group. And since like I was mentioning earlier, I learned about AYA back in like 2001. In 2009, I believe it was, Northwestern said, hey, can we have this young adult patients join the advisory board for the START program? Sure. So then that happened. We started a multidisciplinary working group shortly thereafter. And now we have support groups for patients and families. And it didn't happen overnight. I mean, there's a number of years, and obviously support and money and personnel is helpful too, of course. But it's worthwhile, and I think we've really done a good job. And it's been a struggle, I would say, too, over the years to getting the support we need, but it does impact patient care and patients. And then, of course, these support groups, if nothing else, and also telling patients about resources for peer connection, such as some of these organizations here, True Northwest, Lacuna Law, Versus Sense, etc. And then lastly, I wanted to share with you this. I just came across this new diagnosis guide for teens and young adults from the Children's Oncology Group. And we can put the contact information in there. You can probably just Google it too. But so this is another good resource from COG. And again, not focusing on teens and young adults. I thought I'd share that with you. And thank you. And I'm done with my portion of talk. And I'll turn it over to Jen. I'm going to stop sharing. There we go.
Okay, thanks so much, Karen. I'm going to start sharing. Fantastic. Hi, all. My name is Jen Reichek, and I am a pediatric oncologist here at Lurie Children's. I titled this talk, I Don't Want to Grow Up, I'm a Peds-Onc Kid, and I realized that it kind of dated me or aged me because many people in the audience may not know the reference to a commercial for Toys R Us back in the day. But anyway, here we go. We're going to talk today about transitions between pediatric and adult care. So Karen talked eloquently about the transition of care. And when we talk about the transition of care between pediatrics and adults, it should really be active, planned, coordinated, and really a comprehensive process, helping our adolescents and young adults transfer from the pediatric to the adult setting. And I think about it a little bit. You see here the baton handoff in a relay race, and that's something that has to be executed with real precision to make it successful. And I think that's the same for adolescents and young adults transitioning from pediatric to adult care. And so that is the goal. What does it really look like? I think for some people, it feels like graduation and they feel ecstatic and delighted that they're moving on and considered an adult in the healthcare setting. And for others, it can really feel like abandonment. And before we started sharing things this afternoon, the presenters were having a little bit of a discussion and talking about being asked to be adult when you don't feel ready and how it feels like you're putting on shoes that are too big for you. So how can we make this transition better? It's complicated, and it has to do with understanding who adolescents and young adults are, where they are in their own developmental trajectory, and how we can help them understand the differences between pediatric and adult care and really facilitate a relatively seamless transition between pediatric and adult care. So let's talk again. Karen talked about this a little bit, but there are about 500,000 survivors of pediatric cancer in the United States right now. And approximately 1 in 750 young adults is a survivor of pediatric cancer. And of those folks, as Karen said, about a third of survivors have at least one severe or life-threatening condition as a result of their cancer treatment. And this picture that's at the bottom are members of our Board 39, which Karen was talking about, our young adult advisory board on the adult side, and they were enjoying a White Sox game. Why is the transition of care between peds and adults important? Well, we know that about 80% of young adult cancer survivors don't receive their recommended follow-up care. And it starts when they are survivors in the pediatric setting, and there's a higher rate of attrition as they move on to the adult care setting. We also know that many of our survivors really don't understand their history, and they don't have enough information about their diagnosis and their treatment, and therefore don't understand what their risk for long-term sequelae are, which means that they can't effectively advocate for themselves in the healthcare setting. This lack of care leads to conditions that might be prevented or might be able to be treated at an earlier stage if only folks knew to be looking out for them. And so we really need to empower our young adults as they transition to alert their healthcare providers of the things that they're more at risk for as a result of their cancer treatment. So when I think about pediatric oncology and adult oncology and the AYA population, it kind of works like that. AYAs neither fit into pediatric oncology, nor do they fit into an adult oncology model in a perfect way. And particularly as we transition AYAs from pediatrics to adults, we have to remember that they fit in neither of these settings well. If you think about pediatric care, and I don't know how many people who are watching this are from pediatrics, we're very nurturing, we're pretty prescriptive. We definitely are telling people what to do all the time. And if one of my patients doesn't show up to their appointment, I will find them and I will make sure that they come to their appointment, and we'll call out the National Guard if we have to. In the adult setting, adult medicine is really about empowering the patient and is seen as a collaborative effort between patient and care provider to meet the medical needs of the patient, but also allow them to have some agency in their own healthcare. And in the adult setting, if you don't show up to your appointment, the provider assumes you've made a decision, and then that provider has about 10 extra minutes in their schedule, and maybe they get to go to the bathroom that day. So clearly a really different venue through which healthcare is provided. When we think about adolescents and young adults, they're going through a hot mess of development, right? They're trying to separate and individuate from their parents. They're developing their own identities, including sexual identity, and trying to develop some self-confidence and figuring out really who they are and how they want to be in the world. They're looking to form relationships with people outside of their families and figure out how to have both loving and friendship, genuine, caring relationships. But they're also developing their own independence, both emotionally and financially, and looking towards the future. So we all know that kids are really thinking of the present, and adolescents and young adults are very much present focused. And as they continue to go through their development, they're starting to think about the future and planning for a future as opposed to just thinking about what's happening today. This affects their ability to transition from care. Karen, now I'm having the same problem as you with, there we go. So when we think about transitioning, we really need to figure out where the adolescent and young adult is in their developmental trajectory to be able to tailor this transition to where they're at. We also need their family to be on board to help support that transition. And we have to empower that AYA to gather knowledge, to understand their own history and their potential side effects so that they can inform their healthcare providers if needed about what to look out for. There are a couple of models of transition, and when we think about transition of AYAs with chronic medical conditions, there are many different types of transition. When we think specifically about cancer survivors, the literature talks about two different types of transition. So one is within a larger cancer center, which we at Northwestern have. And so in a larger cancer center, you have a continuity of care as patients are being shifted within essentially the same healthcare system. And the transition between the pediatric and adult practitioners are a little bit easier, both logistically and also physically. Karen and I literally work across the street from each other. And so when we transition patients from the pediatric STAR program to the adult STAR program, if we need to, we can actually walk folks across the street to figure out what clinic they're supposed to be going to. And we can also have the flexibility, if necessary, to do an appointment with all the healthcare providers in one room to help build confidence and trust with the patient family. In a cancer center model, there also can be continued care in one survivorship program, and some other programs have a survivorship program for pediatric cancer survivors that spans the lifetime. lifetime. Karen talked a little bit about the primary care model, where we look out to general practitioners to take the lead and be the focused provider for our AYA patients, and who call in or consult adult specialists as needed. This is a more community-based approach, and it can be done anywhere, which is helpful for folks who live in more rural areas or places where care is more sparse. However, there's a lot more coordination that has to happen. And in this case, the survivor needs to really understand what their healthcare issues are and what the long-term sequelae of their treatment might be, so that they can inform their practitioners who may not be familiar with long-term sequelae of pediatric cancer treatment. There's a lot of talk about stages of transition. I sort of boiled it down to 3 different stages. The first one is envisioning a future. And as we talked about with developmental stages in AYA life, you have to start thinking about future rather than just the present. So when we think about transitioning AYAs from the pediatric to the adult setting, we need to start talking about this transition years before it actually happens, and make sure that we are giving the adolescent and young adult patient comprehensive information, not only about their treatment, but about potential long-term side effects. Then, as they continue to develop, when they are becoming more responsible for themselves, we have to help them within the healthcare setting also build autonomy and start thinking about making their own medical decisions. Many of our patients have been small when they were diagnosed with cancer and had absolutely no choice in the decisions made for them. We do have AYA patients who make joint decisions with their families, and young adult patients who technically are in charge of their decision making when they're talking about treatment. But as always, they want their family's input. We also have to empower our AYA before the transition actually occurs to ask questions and really take the lead, taking the focus off of their parents and their parents' questions and making them the agent in the visit. And then as we approach the age of transition, we continue to increase an AYA's level of autonomy in the visit. We really sort of practice and prepare for the actual transition, and then we execute the successful transition, meaning making the referral and then making sure that that patient is seen in the adult setting and touching base with the patient to make sure everything went okay. There are lots of barriers to transitions. There's a lot of fear and anxiety on the parts of survivors. They feel comfortable within a hospital and a treating team, and the thought of moving not just between teams, but between institutions can be overwhelming. There's a lot of difficulty changing from a pediatric to adult style. We were also talking before this about those of us who have young adult children and how you transition from being a prescriptive parent to being a permissive parent. And sometimes I can tell you from personal experience, it's very hard because you believe that your young adult is not going to make the right choices. And I think survivors sometimes doubt their own ability to make choices too. Again, the lack of knowledge and treatment history and potential side effects can be a barrier on the part of the survivor. And sometimes that's because it wasn't given to them. Sometimes it's because of cognitive limitations secondary to cancer treatment. Sometimes it's because of a language barrier, but making sure that people are armed with their information is really important. And also, some of our AYAs are not comfortable with advocating for themselves in the healthcare environment, and that can cause some distress. There are barriers within the family. There's also fear and anxiety with the family as they feel comfortable with the pediatric setting and the treating team and that style of prescriptive healthcare. But also sometimes parents have difficulty, as I just said, fostering their children's independence and worry that their AYA cannot really advocate for themselves or make sure that they cover all of the things that they should be covering in a healthcare visit. There are barriers on the side of the providers. There can be a lack of communication between providers, but also between the provider and the patient. And the change from helping the patient to an autonomous focus for the patient may leave the patient with expectations that they don't understand. And so they're unprepared for their visits in the adult setting. And again, the lack of knowledge of long-term issues on the side of providers makes it hard for them to take care of AYA survivors. Within the healthcare system, in pediatrics, we're fortunate. We have lots of social workers and child life specialists, and some people have education liaisons and a million different things that really help make a big team taking care of children. Those supports aren't necessarily there or as readily available in adult healthcare. And sometimes providers are just not equipped to take care of young adults who are kind of flaky and don't follow directions. So what is an ideal transition? Well, as we said, it's a transition that's individually adapted to their survivor, both their medical aspect of their life, but also their psychosocial and developmental age and process. It should really occur as a gradual process and start years before the actual transition occurs to prepare the AYA to transition from pediatric to adult care. It should be very structured and organized. And if you Google transition of healthcare for AYAs, there are lots of tools that you can actually use to help facilitate a transition between pediatric and adult care. It should really leave the AYA feeling empowered and autonomous and really good about their ability to advocate for themselves. And it should really include follow-up so that the AYA patient successfully transitions between the pediatric and adult setting.
Jen and Karen both, that was fantastic. You guys covered a lot of ground, and I didn't want to interrupt. We are pushing the time limit here. I didn't want to interrupt because you guys did give so much great information. Can I ask the two of you to answer? There are two really important questions in the chat. Could I ask both of you to answer those questions in the chat while I introduce our next session? Is that good with you too, Karen? I see Jen, you're shaking your head. Are you okay with that, Karen?
Yes, of course.
Excellent. Excellent. Thank you. Thank you. Thank you both.